Assalamu alaikum. Good evening, everyone. Welcome to the career guidance session organized by the Kmdc Alumni Association in collaboration with the Karachi Medical and Dental College. Today, our topic is Interventional Radiology as a Career. Our speaker today is Dr. Saad Rehman. He graduated from KMDC in 2001. He received his training from Glasgow. I would now like to welcome our speaker.
Thank you, everyone. First of all, you people can hear me clearly?
Yes, we can hear you.
Okay. So thank you, everyone. Thank you for the invitation. I will go through the career options of interventional radiology as a career, specifically, and the radiology as a career in general. So first of all, a little bit about me. So as the host, Dr. Samra introduced me that I am the graduate of 2001. So I actually went to the college in last century and graduated in 2001. I did my house job in Abbasi Shaheed Hospital, and soon after my house job, within 2-3 months of doing the house job, I went to the UK. So I actually did my PLAB 1 examination. At that time, it used to be the PLAB 1 during the house job. Once I went to the UK, like most of the people, I had the ambition to become a surgeon. So I worked in the surgery for several years, actually. To be specific, I worked probably around 6 years in the surgery, worked up to the position of the senior registrar. But UK at that time, and in some places still, used to have a pyramid system for surgery. Means you start at the bottom with a lot of people, but only few make it to the top. So after seeing that my career has stalled, so I switched to radiology at that time. So radiology, I did the radiology training and then the subspecialty training in the interventional radiology. And then I practiced in UK as a consultant, and now from last 3.5-4 years, I've been in Qatar working here. Okay. So this is just a picture. This is my classmates, all old people here. So just to show that probably you people recognize two people from these. This is Professor Adil Ramzan, your professor of medicine, and Dr. Ahmed Nawaz, who is probably the president or very active in Hopes. These two guys are obviously my classmates. This guy sitting behind me is the associate professor of neurosurgery in Dow University Civil Hospital, Asim Rahmani. Ali is a physician in Oman, and Imran is a physician, pediatrician. He works in a private sector in Karachi. So first of all, just going to speak about radiology. So radiology, and like you people, when you're now graduating, you're graduating at the time of the era of subspecialty medicine. The time of general medicine, general surgery, and general few things are long gone. In some places, it's still surviving, particularly government hospitals in Pakistan, where you practice most of the stuff. But in majority of the areas, even in the private sector in Pakistan, it's time for subspecialty medicine. People work in the subspecialty areas, having their subspecialty interests. So if you want to do radiology, sometimes people think radiology is maybe just about sitting in a dark room. Radiology has actually evolved a lot. And the concept of just sitting in a dark room has long gone. Obviously, you spend a lot of times reporting the scans, depending upon what's your interest, but you do a lot of hands-on work as well. So radiology is obviously one of the fields where you do not get exposure, either as a medical student or in your house job or internship. So if you want to do it, so how to show your interest? You can do elective, like you can go for a month or 2 months and work in a radiology department as an elective to get the know-how, how the things are done. You can do certain projects or audits while actually working in medicinal surgery, which will be basically radiology oriented projects, like looking at certain type of scans on the patients of certain disease and that sort of thing, which basically shows your interest. And it all depends upon where you want to do your training. In Pakistan, I guess the training is you do your FCPS in a certain field and then you go for the PGship in that one. And I guess doing electives may be helpful. Doing edits and projects may not be necessary. In the UK, what I'm talking about is actually more relevant to the UK. In the America, when you apply for the match, obviously they look at the electives, they look at the orders of projects you have done to see if you have the interest there or not. Okay. Once you get into the radiology training is usually 4 to 5 years training. It varies from places to places. Some places maximum of 5 years. In some places you can actually get out in 3 years as well. But I believe 3 years is not enough. The 4 years to 5 years is usually training time for the radiology. Just like radiology, subspecialty training in the radiology is actually quite beneficial, but it's not mandatory. There are certain specific fields of the radiology, such as the nuclear medicine, breast radiology, and intervention radiology. These three fields actually asks for a subspecialty fellowship training. The rest of the things, you don't need it. You can just start doing it, and while doing it, you can learn. I think the slides are going pretty quickly. I need to go back to the last slide. Okay. So interventional radiology is becoming a separate training program in the United States of America. From last year, they have a separate match system for interventional radiology. It's not part of diagnostic radiology. Similarly, the UK has introduced interventional radiology as a separate training system. And it is happening more and more. But in most of the places, interventional radiology is still as part of the radiology. So you do the general radiology for first 3 years or 4 years, and then you do interventional radiology for another 2 years. So bringing it in total of 5 to 6 years. Next slide, please. So as I said that the interventional radiology now has dedicated training pathways. If you don't go for a dedicated training pathway, that's not a problem. You can do a general radiology. Like if you are training in Pakistan, you can do a CPS in diagnostic radiology for 4 years. After 4 years, and then you can do a 2 years of subspecialty fellowship training. I know certain institutes of Pakistan like Aga Khan and Shifa International, they have well-established IR fellowships. If you want to go outside, a lot of countries have IR fellowships where you can just go and do the work for 2 years, 1 year, usually 2 years, and get the specialty know-how. Now coming into the deeper into the IR, interventional radiology. What is interventional radiology? Interventional radiology is essentially working either in endovascular or in the body cavities while using the imaging. Basically, you are using the X-rays, which is fluoroscopy imaging, which is the live X-ray and ultrasound, and while you are working in body cavities or inside the vessels. Life as IR is actually more like a surgeon's life rather than the radiologist's life. So I hardly do any reporting work. And most of my time is spent in the procedure rooms, which is the angio suites. Here we do all sorts of procedures. It has the IR has a two broad sides, which is basically vascular work, which include arterial and venous work, and the non-vascular work, which is body cavity, such as the work inside the liver and the kidneys and certain type of other work. Okay. When you are working, it is actually a lot of pressure because you have to do the decision making on the spot. So if you are doing an angiogram, if you are doing a procedure called embolization, which is essentially closing of the arteries or closing of the bleeding vessel by using a specific material inside the vessels. So you actually do a live X-ray, you look at the live X-ray and you make the decision then and there, where you have to go and what you have to close. So it's a lot of pressure and it is actually a very dynamic lifestyle. So it is totally different from what we do as a radiologist. What the concept of the radiologist is. So interventional radiology is actually polar opposite of the normal radiology. So this is essentially a slide from a, if anyone is interested, they can actually search for this called Interventional Initiative, the II, on the Twitter, and I think they are on the Instagram as well. So this is the slide from there is the organs we can work in, the liver, kidneys, lungs, brain, gallbladder, uterus, all that sort of thing. What we do, we can dissolve the blood clots. So if patient has a DVT or patient even have a PE, we can go in with our instruments and we can dissolve the blood clots. We can open the blocked vessels by angiography and stenting. We can stop the internal bleeding. The procedure is called embolization. This includes bleeding internally inside the GI tract, inside after the polytrauma, splenic embolizations, liver embolization, pelvic embolization as a part of major pelvic trauma. We all do that. We can treat the tumors by doing the ablation. That's include the cryoablation and as there's a heat ablation. We can keep the vessels open in the peripheral vascular disease, most common in the diabetics. Uh, we can
Everyone,
kill the tube. Hello?
sorry, yes. I just want to interrupt, let everyone know that the meeting will end automatically in 5 minutes. Please rejoin by clicking on the same link. Thank you.
Okay. So we treat aneurysms and we basically treat them by coiling them, means putting a fine metal thread inside to make it block, or we can put a stent across the site of the aneurysm to make it block. A lot of work, a lot of brain aneurysms are now treated by the interventional radiology. I'm not certain what is the situation in Pakistan, but outside Pakistan, a lot of people get treatment of the brain aneurysms by the interventional radiology. Again, the tumors can be treated by the ablation system or by certain drugs where we basically put specific beads inside the tumor. We basically go into the arteries which are supplying the main bulk of the tumor, and we put a specific beads. These beads contain chemotherapy drugs, or in certain cases they contain radiotherapy drugs, and those can be left inside to treat the tumor internally, and patient does not need systemic chemotherapy or radiotherapy because that's being done from internally. Certainly, the fibroid treatment is quite a common thing. The fibroid treatment is quite a common thing. The principle is the same, the embolization principle. We treat vertebroplasty, spinal fractures, basically the crush fractures or the osteoporotic fractures of the vertebral bodies. We put a large bore needle in and then we put liquid cement in it. This procedure is also performed by the spinal or orthopedic surgeons, but interventional radiologists have been doing this for a longer period of time as well. Just like you try fibroid embolization, we actually treat the benign prostate hypertrophy. And it's the same principle. You put the specific beads inside to give the organ ischemic damage, and that shrinks the organ, relieving the symptoms without need for any surgery. So recently, the bariatric embolization has become quite popular. In this bariatric embolization, we actually close the short gastric vessels which supply the fundus of the stomach. It has been shown scientifically that it secretes a certain hormone which essentially increases the hunger, and when that hormone is being suppressed, the desire for hunger goes down. So no need for bariatric surgery. This is done in that way. Obviously, the results in a long term are not yet comparable with the bariatric surgery because this is a new procedure, but in the other cases like fibroid and prostate, they are equally comparable. And a lot of work in the venous side, like we can do the remove the blood clots. We can put certain devices inside to prevent the blood clots happening, or if the blood clot is there, to prevent it moving away from somewhere else. Okay, next slide, please. So this is just a snapshot of the loads of the procedure which are done. Essentially what I was discussing in the previous slide, this slide is more or less a different way, tells us about what we do is the angioplasty. Most of the people are aware, which is essentially opening of the vessels either by the balloon or by placing a stent inside And then there are a number of other procedures. I'm going to go into the detail because then the presentation will become very uh, technical. I want to avoid that. So let's move on to the next one, please. Next slide, please. So radiology obviously is very important in diagnosis of any malignancy. The CT scans and MRI scans forms the basis of diagnosis for any malignancy, and that's the same case in the liver. Once the radiological diagnosis is made, the patient comes to interventional radiology, and the first time what we do is we do usually an ultrasound guided biopsy. That biopsy goes to histopathology, and that confirms the presence of the tumor and what type of tumor and what the treatment plan can be done. So among the different treatment plans, the interventional radiology has two large inputs. One is local destruction of the tumor, which is mostly done by the ablation, where we put a large needle, a large thick needle, which essentially is a heat probe at the tip, and it basically burns the tumor internally. Or it can be a cryoablation, where instead of heat, it produces minus 70 degrees Celsius temperature to basically ice freeze the ball. One of the other options is essentially including injecting the absolute alcohol into that malignant part, but that is usually done for a smaller deposits or recurrent malignancies, which are basically coming back in a smaller deposit, not for the primary tumors. The other big treatment, as I was explaining in the previous slide, is the embolization, where we go inside the hepatic artery and we essentially deploy or we inject the beads, microscopic beads in forms of clusters. They are loaded with chemotherapy agents or radiotherapy agents, and then they sit in the tumor, slowly releasing the drug over a period of up to 6 weeks and killing the tumor. That basically saves the patient from having chemotherapy. Sometimes they need chemotherapy later on, but while they are actually having that sort of a treatment, they don't usually get chemo or radiotherapy at that time. And these modalities are highly effective in treating the liver malignancies, particularly the HCC and colorectal metastasis. Obviously, this all work in tandem with chemo-oncology treatment, such as the chemotherapy, radiotherapy, and the surgical excision treatment. And it is the decision by the multidisciplinary team meetings what sort of a best treatment is suited for patient. But from the IR perspective, this is what we can achieve from. So this is just basically to give you an idea. The interventional radiology is actually very different from the diagnostic radiology, and it is a highly hands-on field, very exciting, but on the other side, very demanding as well. So next slide. So that was the end of the presentation. Now I'm open to the questions. Anybody has any questions, let me know, and I'll try to answer the questions.
Thank you so much for the presentation, Dr. Saad. Okay, so for questions, I wanted to ask you, how did you pick IR after surgery didn't work out? In my head, they're both very different fields.
How do I pick IR after
surgery?
Okay. What made you choose interventional radiology? So as I was saying is that my previous aim was to become a surgeon. When my career was not progressing in surgery, so I switched to radiology. When I came into the radiology, I came with a mind to do the interventional radiology, because I have seen interventional radiology as a surgical registrar, what interventional radiologists do for us for the other specialties. So I was well aware of this specialty before I came in, but the training pathway to the interventional radiology goes through the diagnostic radiology. When I actually did the training, now it has been separated. You can actually just choose interventional radiology, where you will do some basic diagnostic radiology, but more interventional radiology. So that's why I went into the radiology. So I did the 4 years 4.5 years training of diagnostic radiology, and then 2 years fellowship in the interventional radiology. And the reason I was that is basically I wanted to be part of the treatment, part of being hands-on, and I just like being the interaction with the patients, which if you basically choose radiology, the interaction with the patients is reduces a lot. So that I don't want to sacrifice. So that was one of the big reasons.
So how do you find a regular day in your life is now as an interventional radiologist?
Okay, so the regular day is we go in the morning. There is usually a booked list of procedures every day. So basically, clinicians and clinicians keep on putting the requests on the patients which they need certain type of procedures. Okay, some of those procedures which we get the requested, we usually discuss it in the during the daytime with the clinicians. What are the demands and what is the expectation, and what we can provide them. And then we book the procedure next day. So once we go there in the morning, we usually call which we call a huddle. Basically, all the doctors and nurses and the technicians come together. The head nurse usually, which has come early, has inquired with the patients, so making sure the patients are ready on the ward and there is nothing change in the patient situation overnight. So once we have done the huddle, we start calling the patients one by one, and we usually do the procedures, whatever the procedure is required. In between the procedures, I usually do the report of the procedure. Some of the procedures are done by my fellow, the people who, the fellows which we are training. Some of the procedures are done by me and myself. And in between, whatever time I have, I do consultations with the patients. We have clinic like telephone consultations. The patients who are electively booked for certain type of procedures, we call them, we ask them, we explain to them what is the procedure they are going to have. We used to have a clinic, but that was stopped during the COVID time, and we have not restarted it. So we are doing the telephone consultations. That's part of that, and obviously I do some reporting, which is all related to the procedures which I am doing. So the only reporting I do is essentially scans related to the patients which are on our list. There is a question here. It says, can we say that oncology and cardiology are the dominant fields in interventional radiology? So cardiology is not the dominant field because we do not work in the heart. But the basis of the interventional radiology is similar to interventional cardiology, basically angioplasty and stenting. But that's actually a very small part of our work. A lot of other work is a lot of other things. Oncology, yes, oncology is actually a dominant field because more and more oncology treatments are coming into interventional radiology. From the diagnosis to the treatment, a lot of cancers come back, unfortunately. So you have metastasis, you have local treatments, because we offer local treatments as well. Once you have treatment done for a certain type of tumor and the tumor goes away, and then the person comes back after 6 to 8 months with 1 or 2 metastatic deposits somewhere. So the trend was to give them chemotherapy again, radiotherapy again. That trend has changed. That trend has changed to basically a local therapy. So we will go after that, specifically after that metastasis. For example, somebody has come back with a lung metastasis or a liver metastasis. Maybe a woman is treated for breast cancer. Now she's back with liver metastasis, only 1 or 2. We will go after that, and we will basically ablate the tumor or do an alcohol injection to kill that specifically that deposit, rather than patient having another 6 weeks or 10 weeks of chemotherapy. So yes, oncology is a dominant field, is a dominant part of our work in interventional radiology.
Dr. Saad, can you talk about your pathway for applying for training?
Sorry, line for training? How do you...
Applying for training, the pathway.
The pathway for training.
Yes.
Okay. So the pathway for training is still the big pathway is going through the radiology. So you go and you do the radiology training for 4 years, diagnostic radiology training. I am aware that in Ahan, when you do diagnostic radiology training, you actually get 3-month blocks twice in that 4 years So essentially 6 months in total doing the interventional radiology. So they will give you a taste of interventional radiology. I have heard that you can actually ask for another 3 months, so making it in total of 9 months. That is for Aga Khan. I don't know, not know about the other places. But in the UK or in the US, if we are talking about, so you will do 4 years of general diagnostics radiology training. Obviously, that will include taster of 3 months or 6 months into interventional radiology as a part of rotation. Then after 4 years, once you have done the 4 years training, you will go and do the fellowship, which is basically for 2 years, interventional radiology fellowship. Now, interventional radiology also includes interventional neuroradiology, basically working in the brain, and pediatric interventional radiology. Not every fellowship covers every aspects of the training. So you have to look into your own interest and what you are doing. So basically, you will go and do the 2 years of fellowship in Pakistan, Khan, Shifa International, and Zauddin. These three places are doing their fellowships, interventional radiology, and I think Shaukat Khanam is doing as well. So, or in the UK or in the US, you will basically apply for the fellowship programs and you will get selected into one of those and you will go and you will do that for 2 years of interventional radiology fellowship. That brings it to the 6 year in total, and now you are qualified as an interventional radiologist. Then you can start working as a physician, as a consultant, depending upon where you are based and where you want to work. The things which have changed in the last 3 years is in America there is a separate match. So previously you used to go to match for radiology, do the radiology training, and then do interventional radiology fellowship for 2 years. Now there is a separate match, and it is a 5 year program. In that 5 year program, they will basically do 2 years of diagnostics radiology training and 3 years of interventional radiology training. So in total, you will do 5 years of training and you will become an interventional radiologist. UK has also started a similar program from last year. So last year was first intake in UK, and the 2 years ago was the first intake in US. So now these programs will become more and more. So what is happening is the standalone interventional fellowships will start disappearing because those positions will merge into these dedicated training pathways.
Okay, and then what did your pathway to Qatar look like after that?
Okay, Qatar is just an opportunity which came. So I was working in the UK. I was there for 2 years, 3 years as a consultant, and then the opportunity in the Qatar came because they were expanding their interventional radiology services. They needed people. One of the people from here, actually, the lead of the department, he came to London. He was meeting people, so he met me through a known contact, and they offered me a job. So I moved to Qatar. Qatar, on the other side, for the people like you, for the people students, Qatar has their own residency programs and as well as the fellowship programs, not just radiology, in almost every field of the medicine. Hamad Medical Corporation, which is the HMC Hamad, HAMAD.QA is the website, Hamad.QA. They basically announces the residency programs every year. Their intake, I think their intake happens in August every year. So they announce the programs in November, do the interviews, I think, in February, and then they start the training programs in the August. They have separate fellowship training programs as well. If you just want to come and do a fellowship, we have a Pakistani fellow who was trained in Aga Khan, and he is now doing it in fellowship with us, and he only came for the fellowship. So yes, there are opportunities here as well. So how can be IR useful for cancers in which the tumor has spread to most part of the body? Okay. In this situation, when you are talking about when the tumor is spread to the most part of the body, then you're talking about the palliation. What IR can do is basically IR do few things, which is essentially the palliation depending upon the primary tumor and the bulk of the metastasis. So still, if the patient's tumor has spread to the different parts of the body, but you have got, for example, you have got a bulk of metastasis to the liver, but it has spread everywhere, we will still do and perform the beaded chemotherapy, which is called TACE, transarterial embolization. What is our treatment? We essentially go into the hepatic artery, put the chemotherapy beads, and then close the hepatic artery. It does not obviously cure the thing, but it essentially reduces the burden of the tumor in the liver. So what it does, it slows down the liver failure and the symptoms which patients are getting from the liver failure. That actually helps. In terms of other thing, we also do the nerve blocks. So if patient have a pancreatic cancer, they get severe pain. We basically do celiac axis block. Under the fluoroscopy, we inject long-acting anesthesia with the steroid along the celiac axis of the vagus nerve, and that actually helps with the intractable pain. We a lot of patients with the widespread cancers have the recurrent ascites, recurrent pleural effusions, nutritional problems. So we basically put a drains, permanent drains, not just temporary drains, permanent drains, which essentially stays in their special type of drains, which stays in for up to 6 months and keep draining, slowly keep draining the fluid from the body cavities wherever they've been put. We put some certain type of tunnel lines, which essentially go from the arm, which is called PIC line, and patient can have long-term chemotherapy and nutritional support, which can last up to 3 months to 6 months through those lines. And because they are not through the neck, they do not pose the risk of internal jugular thrombosis or the central venous septicemia. So there are a lot of ways in which the IR can help in the patients which are on palliation.
Dr. Saad, what do you think is the most challenging procedure that you have to do?
Sorry, repeat that again.
I was asking you, what do you think is the most challenging procedure that you have to do?
Most challenging procedure which we have to do is the neuro intervention. So basically, if you have an aneurysm and you are coiling that aneurysm inside the brain, there is always a chance that that aneurysm can rupture. So if the patient has the on-table rupture, that essentially means patient arrests. So when we do the neuro work, we actually have the neurosurgeons stand by and the whole anesthesia. Obviously, the patient is anesthetized, but the whole anesthesia team available in case of anything goes wrong. They can take over and they can help us to resuscitate the patient. And obviously, if the aneurysm ruptures inside the brain, then neurosurgeons has to do an emergency surgery then and there. So their presence is very, very important. So neuroradiology work is actually very challenging and very stressful. That's one of the things because the margin of error or the time you have to respond is essentially none. You have to have everything available ready with you if anything goes wrong. So that's one of the most challenging part which I feel. Okay, his question is, do you face any significant language barrier with the patients when you are in Qatar? We students usually try to avoid Gulf countries because of that reason. You are actually right in that way because a lot of patients are obviously Arabic speaking. However, yes, there is language barrier. There is language barrier, but there is always somebody around to help you out with the Arabic language. If you look into this way, that 99% of the nurses working in the Gulf countries are from Philippines and India. These are the two nationalities which basically form the 99% of the nursing profession. So none of them speak Arabic, yet they work there. And obviously, you can, I don't know how much is it, but the nursing care is actually, nurses have more exposure to patients than the doctors. For the small needs, they are always seeing the patients. So they manage. I agree to an extent that there are issues, but I have seen many Pakistani doctors in Hamad Medical Corporation in different training grades, in different specialties, medicine, surgery, everywhere, because obviously as an IR, I come across with almost every specialty. So I have seen everyone and there are people training with it. Yes, there are certain language barriers, but to be honest with you, the spoken Arabic is actually different from Quranic Arabic, which we read, and you once you work in an environment, you stay in an environment, you start picking up words. There are plenty of words which are common with Urdu, and you can overcome the language barrier if you work hard on that. But yes, there is some language barrier, no doubt about it.